I just wanted to share with you some of the results of the study we made with this drug. Just a short history of the drug. Indeed, interferon is a natural molecule that has been discovered in 1957 that is indeed produced by our own white blood cells, leukocytes, when we are infected, for example, by a virus. So it's an endogenous protein that enhances our immune response and enables our own body to eliminate cells that are infected by a virus, for example, and also cells that become abnormal, malignant, and cancerous. And as you can see, it has been approved about 30 years later as a drug to treat first a rare blood disease, hairy cell leukemia, but very soon there was interest, and we found that this drug was also efficient to reduce the blood counts in patients with elevated platelets, ET, or too many red blood cells, PV. You can see here that this molecule and now drug has a wide range of activities. It can target directly and kill cancer cells, but also one of the interests is that it has a lot of impact on immune cells and enhances our own immunity. And this is also one of the limitations of the drug that, as you know, may also induce so-called autoimmune diseases or reactivate autoimmune diseases through this mechanism. There were many, many small studies that were reported using this drug in PV patients for many years, but not a big one. But anyway, based on these results that were quite nice, I have summarized on this slide the 4 main international guidelines about PV management, the American ones from the United States, 2 European ones, and the British guidelines. And as you can see, now they all agree to say that when you need to use a drug as a first line for PV patients, then the best choice is either hydroxycarbamide or interferon alpha. So why should we choose one or the other? So this is more complicated, but we have now some evidence to say that maybe interferon can produce better results on the long term. For example, there have been many reports of normalization of bone marrow histology, histopathology. This was shown in PV made almost 10 years ago by the Nordic group, but also more recently by Dr. Silver in early phases of myelofibrosis. So this drug, after certain time, few years of utilization, can restore a normal bone marrow morphology. So this is a good point. The second point that raised interest about this drug is that it can induce so-called molecular responses, meaning that you can see the quantity of cells harboring the JAK2 mutation go down along with your treatment, and sometimes even you can achieve so-called complete molecular response, that the mutation is no longer detectable after some years of utilization of the drug. So what we have now as scientific evidence is a so-called phase 3 comparative trial that compared head-to-head hydroxycarbamide and a new form of interferon alpha, the ROPEG interferon alpha 2B. The advantage of this new form is that it's a very long-acting, so you just need to make one injection every 14 days. And even my patients now, even once per month by using a pen. So it's very easy to use. And this new form was compared to hydroxycarbamide. And with different endpoints. After 12 months, we wanted to see if the two drugs were capable to induce hematological response to normalize the blood count, and on the longer term, to see if one was better than the other to achieve these more ambitious endpoints than just normalizing the blood counts, but maybe inducing these molecular responses. We showed the results after 3 years, and you can see here, for example, the proportion of patients in green treated with hydroxycarbamide and in red with the interferon who could achieve normalization of the blood counts. So reduction of the hematocrit without phlebotomy, normal leukocyte, normal platelets. And you can see that if hydroxycarbamide does very well during the first year of therapy, then after 1 or 2 years of treatment, interferon appears to be better. 70% of patients achieve this compared to 50% in the hydroxycarbamide group. The same for the reducing the JAK2 mutation. As you can see, on the long term, there's a clear difference in the proportion of patients who see the nice decrease in the JAK2 mutation compared to much less in patients receiving hydroxycarbamide. The other point was the tolerance of the drug, because maybe some of you have a poor experience with non-pegylated forms, etc. And as I mentioned, this molecule is synthesized when we have a viral infection and is responsible for some of the fever, chills, etc. that you experience. So when you inject the drug, it's just like you had flu for a few hours. But the good surprise with this very long-acting form is that there was no more adverse events in the group of patients who received hydroxycarbamide compared to those who received interferon, although they were different. The safety profile of both drugs is quite different, and is what we know already. There were more hematological adverse events in patients receiving hydroxycarbamide and more of these immune-derived adverse events in the group of patients receiving interferon, but overall, there was no more discontinuation with interferon compared to the patients treated hydroxycarbamide. So this was a good news for our patients. And so the results of these results made a big improvement, I think, for us and for the patients, is that for the first time we have a form of interferon that is really approved in the indication of PV, monotherapy in adults for the treatment of PV without symptomatic splenomegaly. That's the label given by the European agency that is valid since February across Europe. So this is really a big improvement. Another point I wanted to highlight today is that in the previous guidelines it was mentioned hydroxyurea or interferon preferred in younger patients. Why? Because it was poorly tolerated, and there was this conception that it was poorly tolerated. So we could look in the PROUD study PV and compare the efficacy and tolerance in patients younger and older than 60, because we had a quite balanced population, about 50 patients in each group category, in each of these arms. And indeed, there was no difference. Younger or older than 60, there was still better efficacy of interferon compared to hydroxyurea, and also higher rates of molecular response if you are younger or older than 60. So benefit for every age. And again, for the tolerance, the important point is that what we call the adverse drug reactions, so the adverse events that are related to the drug that the patients indeed received, you see that there was no difference, even less serious adverse events in the group of patients treated with interferon, older than 60, compared to those receiving hydroxycarbamide. So this misconception that it's not well tolerated if you're older is not true, at least with this new form of interferon. The last point is that one peculiarity of this drug compared to all others that we use to treat patients with MPN is that sometimes you can stop the treatment and nothing happens. We were surprised to see, for example, in our phase 2 study we did in France, that on the long term, more patients stopped the drug because they were they had normal counts without symptoms than those who stopped for toxicity. When you stop interferon, that's the orange line for toxicity, it's usually within the first or second year. If you can tolerate the drug after 1 year, then the probability to stop because of an adverse event is very low. In contrast, you accumulate nice responses, and although it was not scheduled in the trial, people tried to stop the drug because the blood counts were completely normal, no symptoms, and let's see what happens. And then we went back to our center, and we could identify more than 300 MPN patients who received interferon at any time point during the course of their disease. And among them, we selected the patients who had stopped the drug. There were almost 150 patients. The reasons for stopping were in half of the patients toxicity, again, but unexpectedly, because this was not, again, neither a recommendation or guideline, local guideline, we noticed that 1/3 of patients stopped because they were very well with normal counts. And what happened to these patients? Indeed, we found that about 30% of them could remain without any treatments and normal blood counts for a long time. The median time was 46 months, for example, and now it's even longer. So some of these patients, are they cured? We don't know. But for the longest patients of my patients, then we now have 12 years after discontinuation of interferon and normal counts, no symptoms, etc. And when we looked at what could possibly predict the chance of remaining with these normal counts, one factor that appeared is this molecular response. You can see on this graph, here you have the probability of remaining without treatment, and here the amount of JAK2 mutation at the time of discontinuation. And you can see, for example, if your JAK2 is no longer detectable when you stop interferon, it's 0 here, then the probability to remain without treatment for a long time is very high, almost 80, more than 80%. If you still have a 5% JAK2 mutation, then you still have a good chance, 60%, to remain in complete remission. If you go down to 10%, to 10%, then the probability decreases, but it's still not negligible. But you see that after 20, if you still have more than 20% of JAK2, then it's quite, the chance to remain without treatment remains very low. So that was what I wanted to highlight today. So one question is it the best first-line treatment for PV? Probably, if possible, because it specifically targets the malignant cells. That is different from the hydroxycarbamide effect. We have these long remissions without drug that even if it's for 2-3 years, I think our patients are happy to have no treatment for a couple of years, and then if they relapse, we can restart. So that's also a good point. It has, however, it's not for everybody. It has well-defined toxicities and also contraindications. We can go through this if you like in the discussion, but it's not for all patients. But if you select well the patients, then probably it's a good thing. And the idea here is that at the contrary of other drugs that relieve the symptoms, avoid the complications, but do not necessarily change the very long-term course of the disease, maybe here we have a drug that is able to change this evolution, to reduce on the long term the incidence of vascular events, to decrease the risk of evolution and transformation of the disease. And we also have an ongoing study that has just started in UK, and I think has the support of MPN Voice, that is called Mithridate, that we will also start, I hope, soon in France, that will also compare interferon alpha to hydroxycarbamide and ruxolitinib. So the 3 drugs will be tested in the study as a first-line treatment of PV, and that will also probably give very important information on the respective role of these different drugs. So that's all I wanted to highlight, and I would be happy to answer your questions.
Question from Canada. You already saw this question. What is the difference between JAK2 positive and JAK2 negative PV?
Thanks for Canadian patients. And I also noticed that there was 1 French patient online, so bonjour. I'm really happy. Well, that's a very important question. JAK2 negative PV is questionable. Is it really polycythemia vera? As you know, virtually almost all patients with polycythemia vera, the so-called myeloproliferative disease, have usually the JAK2 mutation. There are few patients who have a different mutation, the so-called exon 12 JAK2 mutation, that is a bit different than V617F, but results in the same activation of the cells. And the proportion of true PV without JAK2 mutation is probably very low, around 1% of patients in whom we don't find this mutation. So to my knowledge, there's no enough of these very rare PV cases without JAK2 mutations to have a clear indication of a difference in terms of risk of the disease, etc. Maybe they have less risk of thrombosis, but it's not clearly proven.
Thank you so much for your talk and also for your wonderful work in promoting interference. I had 2 questions. One is, now that the ROPEG is available, what will happen to Pegasus interferon? Do you know if it will continue to be produced? And the second question is, would you advocate trying to discontinue Pegasus vis-à-vis trying to have only a small maintenance dose every 4 weeks?
So I will start with your second question, because this is really a very good point, because once the drug will be available, reimbursed, etc., the indication is clear, PV, while Pegasus doesn't have an indication for this drug, so it's prescribed off-label. So in terms of economy, I think, or health authorities, probably we will have to switch from Pegasus to raw PEG interferon when available. Although if I have some patients who have very small doses of Pegasus, so is it useful to change? Maybe I will try to continue, because if they tolerate very well, the drug is efficient. And I forgot the first question, I'm sorry.
The other question is discontinuing the drug vis-à-vis a maintenance dose. Weeks.
I would say that with my patients, I say, what is the risk if we discontinue? At the end, you follow your blood counts. Usually there's not a rebound, within a few days, but it takes months, and you see progressive re-increase of hematocrit, etc. And when it goes up again, well, we restart the treatment, and that's it. So, and we still have a chance of a long holiday without any drug that patients usually enjoy.
Thank you very much.
Hello. Thank you, Professor. It's really interesting, but it's far too much for me to take in one go. Can you give us a reference so I can look your research up on the net, please?
On the
the
online
whole thing as well, please, because you're giving us bullet points. I'd really like to. I may not be able to understand it all, but I'd really like to read it all.
There's not one global review summarizing everything, but there are some references according to the studies, etc.
Okay.
So, thank you.
I just wanted to ask about the phase 3 study. Was I right in reading that there were 45 participants?
The numbers were probably for patients older than, are younger than 60.
Right.
No, in total there were about 350 participants at the beginning of the study, and for the long-term study there were about 200 patients. But the numbers you mentioned probably are when we split younger and older than 60 in hydroxycarbamide and in interferon.
Oh, okay, thank
probably.
you.
Maybe I'll just ask one online question as well while you pass the microphone. A quick question. Doing mutation testing, the question was, is it better to do it on the bone marrow or the blood?
Well, we have now good evidence to say that it's not useful to do it on bone marrow. And we have similar results and comparable results on blood, so much easier and less painful.
Okay.
Yes.
So, and that's only for mutation testing. You still need a biopsy to make a diagnosis, correct?
Sometimes. We don't like to do biopsies ourselves, so don't impose it to
This
patients.
is one last question, then
your
we'll put the rest on the panel. Yeah.
Your study looked at the effect on both PV and ET, but the approval was only given for PV. Is an approval for ET in the in process?
No, the study, indeed, PROUD and continuation PV were performed only in PV patients. That's why the approval is for PV. There's no study in Europe, at least, in ET with this drug. I heard that in the United States, they want to do a study as a second-line treatment after failure of hydroxyurea in ET patients. So maybe we will have some data that could help to have the approval for ET. But I would say, I shouldn't say that, but we use Pegasus off-label for many years. So once we have one drug approved in an MPN, which is PV, I think it's really better to use it also in other MPNs if needed, like ET or MF. Thank you very much.